Hi again, everyone. This is Alex Torres, the Assistant Medical Director for Broward Sheriff's Office. I'm going to be discussing pain management and trauma during this education module. So in the trauma setting, trauma patients typically have a lot of things going on. These are high stress environments, multiple injuries, high adrenaline, and there's always a lot of things to do for these patients. So pain management is not necessarily always thought of as the first thing to take care of in a trauma patient. However, this is not something that we can allow to go untreated or unrecognized. So I'm going to discuss kind of some of the reasons that we want to address pain management just for the acute setting, as well as kind of some of the long-term complications and considerations to think about when we're managing trauma patients, especially when it comes to pain. In the trauma setting, traumatic pain tends to arise from different things. So as I'd mentioned previously, these are typically kind of multiple injuries that can have long-term effects, things like that. So when it comes to traumatic pain, multiple injuries, very common in traumatic patients, especially the level 1 and level 2 trauma patients that we encounter. They don't have an isolated single system injury. So when you have one injury, obviously you're going to have some discomfort, but when you have multiple injuries, it compounds that pain. So that increases the pain that these patients experience. So even more reason that we need to address that pain and try to get some control over. Another reason that traumatic pain is something that needs to be taken care of and addressed is not because of the discomfort specifically to the patient, but because of the impact that that discomfort is having on other body systems. For example, when you have significant amount of pain, you can have tachycardia, your metabolic rate increases, respiratory rate increases. With that, you have a decrease in your CO2. Your acid-base imbalance becomes more pronounced. You go into lactic acidosis, anaerobic metabolism, and you can have actually dehydration through insensible water loss. So whether that be diaphoresis, whether that be tachypnea, whatever it may be, but these are how it impacts other body systems. So as you improve their pain, heart rate goes down, their breathing becomes more controlled, they become more comfortable, you can actually decrease that metabolic demand on the body. So when it comes to the metabolic demand, that's the big one, because this is where it comes down to. The faster your heart's working, the faster your body's metabolism is working. Essentially, your body's running a marathon. You are having breakdown of cells, you're having lactic acidosis, that's worsening your pH. That leads to cardiovascular collapse, hemodynamic instability. So it can be a really slippery slope. Is pain the number one treatment for that? Absolutely not. But it's a component in the treatment of the metabolic processes in the body. So you want to make sure that you address that. The other thing that in the pre-hospital setting is not something that we are very adept to seeing or encountering or really getting feedback on, unfortunately, is how is traumatic pain impacting these patients in the long. So some of the things that come up are the quality of life. So if you have acute pain even while you're in the hospital, or in the acute phase or subacute phase after the treatment of the hospital, it's impacting your ability to do your activities of daily living. Do you need assistance, occupational therapy, physical therapy? Is the pain limiting your willingness to want to get up and do things around the home or to go out? So those are things you need to consider. The ability to return to work. If you're in significant pain, you can't return to work, or you've now become depressed because you are in so much pain or you had this traumatic experience. One of the pictures that I put is from the National Health Service, National Institute for Health Research. In the right side of the slide, talks about how depression reduces the return to work after hospital admission for unintentional or traumatic injury. Having that, it actually impacts now the workforce. That impacts that patient, their family, their ability to earn an income, disability claims. So this can have a very long stretching effects if we are not managing pain adequately. So the other thing, there's an association between acute pain and inappropriately controlled pain and the development of PTSD in the future. Again, that increases the risk of mental illness, can impact quality of life, return to work status, and things like that. And then finally, the risk of developing chronic pain. There's always a risk for developing chronic pain. And obviously you have elderly trauma, pediatric trauma. That's a little bit too much to cover in just one setting. But patients that have poorly controlled acute traumatic pain tend to have an increased risk of developing chronic pain in the future. So another reason we want to make sure to treat the pain acutely, because we are actually making an impact in the pre-hospital setting on things that can happen weeks to months to years down the road. So the more we can do to improve that patient's quality of life and improve the outcome for that patient, we need to be able to do in the pre-hospital setting. So when it comes to managing pain and trauma, there's just some key points and considerations that I wanted to discuss. And this is kind of coming from personal experience. So some anecdotal evidence coming also from the American College of Surgeons trauma quality programs and their best practices, some of the military medical guidelines, and then also coming from the Broward Sheriff's protocols. So These are going to be some of the things that we're going to talk about kind of going down the road, but the key points that I wanted to touch on are going to be that we have to understand that pain is multidimensional. So there's obviously the sensory input, the physical aspect of feeling the pain, and there's also the emotional component. How do we deal with that pain? What are the long-lasting effects of that pain? So it's not just a sensory input and a response. So you have to understand that there's an emotional component. How do people respond to pain? Some people stub their toe and scream as if they're getting stabbed. Other patients get stabbed and they're kind of hanging out drinking a cup of coffee. I've had that patient in my emergency department with 2 stab wounds and he's holding a cup of coffee. Everyone responds to pain a little bit different. So understanding that there's a multidimensional component is important in terms of how we manage these patients' pain. The other thing, which kind of goes along with any assessment, is you want to identify what is their initial assessment of pain. And you want to frequently reassess, especially after you provide intervention to that. So whether it be kind of talking to the patient, whether it be pharmacologic, non-pharmacologic, whatever kind of intervention you're going to make, we want to assess that pain after that. So frequent reassessments are phenomenal. When it comes to the goals of pain management, we have to make sure that patients understand that our goal is not to make their pain zero. So we are not able most of the time to remove the patient's pain. What I typically do in my practice is I tell them, I say, hey, look, let's be realistic about expectation management with pain control. I'm trying to get your pain better. I'm not going to be able to make it go away. If you have a deformed forearm fracture, I'm not going to be able to make your pain go away with even pharmacologic medication. I'm going to make it better, but I'm not going to make it go away. So expectation management and letting them know that that's what your goal is. So I frequently tell my patients, hey, right now we're at a 10 out of 10 pain. Let's aim for a 50% reduction in your pain. And then you set that expectation. You've now set a goal. You give them ABC medication, reassess, hey, how's your pain? It's a 7 out of 10. Okay, so we made about a 30% improvement in pain. So here's a little bit more, and it kind of helps guide how you're going to redose your medications. And this is true in the pre-hospital setting, inter-facility setting. To be able to have those conversations with the patients and set expectations will actually help the management. And from an emotional side of things, it will also not make the patient any more upset that their pain is not gone, and those kinds of aspects. And in the long term, it kind of helps, I think, their emotional state and understanding of their pain. We discussed already frequently reassessing. One of the big things that is easily forgotten, because especially in the ALS world and the hospital world, we have a lot of tools in our arsenal, but we don't want to forget about the non-pharmacologic options. So deformities, splint them. What are our options with regards to cold, heat? Can we put the patient in a different position, a position of comfort that's not going to impact our ability to safely care for them? And then something, again, understand this is a multidimensional component. There are calming techniques. How do you talk to the patient? Tell them, hey, take a deep breath. I'm here with you. Do you hold their hand? What do you need to do to kind of help calm them down as a non-pharmacologic way to treat them? Something else that actually comes from the best practices is a lot of times we're like, oh, we have a very short transport. They have plenty of medicine in the ER. Don't worry about it. The recommendation is actually treat the pain. Even if it's a short duration transport, treat the pain. So you can give them a dose. A lot of times you get to the ED, even if it's a trauma, it may be a little bit of a delay by the time they actually get pain medication on board, because now the trauma team's going through their initial assessment, secondary survey, trying to figure out what their imaging, antibiotics, tetanus. There's a lot of things happening, and pain may not be the first thing that the trauma team's going to address. So if you can address that even during a short transport and relay that information effectively to the receiving team, you'll actually make a pretty big impact in that pain control. So lastly, one of the big key points that I want to bring up is know your medications. Know what you have, know what the mechanism is of that medication, know what your side effects are so that you can prepare for any complications that may arise from administering that medication. So we're going to talk a little bit about some of the medications that we use in trauma, both in the BSO world, non-BSO civilian world, and then some of the military world. So we can kind of just see what the recommendations are out there and see how practice may be changing in the future. So here we have the Broward Sheriff's Office protocol for pain management. Here it's talking about that obviously you want to have the patients on continuous monitoring, so continuous cardiorespiratory monitoring at end tidal CO2. So it gives you your parameters for what you're trying to maintain, your SpO2 95, end tidal 35 to 45. You want to monitor your blood pressure, respirations. And again, you want to have your baseline set of vitals, and then after you administer whatever intervention it is, reassess. And the reassessment comes with vital signs. In the adult patient, and again, we're kind of talking over here for adult trauma. In the adult setting, according to BSO protocol, fentanyl is the frontline medication for pain. Ketamine is preferred for hypotensive patients, or those who have contraindications to opiates. So whether it's allergy, patients that don't want opiates because they have a history of dependence, whatever it may be. But fentanyl otherwise is your first choice. Protocol here is reading 100 micrograms slow push, and you can repeat it after 5 minutes as needed for a total dose of 200 micrograms. When you're administering any opiate or really any medication that's going to provide analgesia, you want to make sure you monitor the patient's respiratory status, make sure their mental status, and you want to be aware of the complications. So for fentanyl, for example, rigid chest syndrome and respiratory depression. Sometimes you can get nausea, vomiting when patients get opiates, so Zofran. So just understand these might be complications, so to have it ready. For continued pain management, according to this protocol, is the ketamine should be given after fentanyl, max dose for severe pain. Ketamine, the pain dose, 25 milligrams. You can do it 2 times every 5 minutes as needed for pain, with a max dose of 75 milligrams for a max dose. I'm going to talk about the ketamine here in just a little bit. I'm going to talk about a bunch of different medications on the next slide, but this is the BSO protocol. This is what we expect. If there's any issues with this, concerns with this, please bring it up so we can have a good, productive discussion about it. And we can kind of go further to how can we improve practices. If there's deviations from protocol, let us know why. Obviously, we're always looking to improve how we deliver care to patients and make sure we adequately maintain good patient care and pain management. The last thing on the bottom of this slide is morphine. That's a secondary if the fentanyl is on back order. You got to continue to remember that morphine will have more of an impact on the patient's hemodynamics typically than the fentanyl will. And like I said, I'm going to kind of talk more about the dosing and stuff going forward. So per protocol, to be compliant with the protocols, this is what you're going to do. Fentanyl frontline 100 micrograms. You can do it times 2. After that, if it fails, ketamine 25 milligrams. You can repeat that 2 more times for a max of 75 milligrams. On this slide, I'm going to discuss the actual medications for the pharmacologic management of pain. One of the big things is kind of a continuation from the previous slide, but definitely want to bring it up because it's going to be mentioned with every one of these medications, is that weight-based dosing is not just for pediatrics. We use it in adults to provide adequate pain management. You need to do weight-based dosing. So one of the most frequent reasons for inadequately controlled pain is that it was not dosed properly. That being said, follow your protocols. The protocol says fentanyl 100 micrograms, ketamine 25 milligrams. Do what is in the protocols, but I need you to understand that if you didn't get the response, it may be because of a weight-based dosing problem. Give us feedback. Let us reevaluate those cases. It happens in the emergency department all the time. A lot of times the vials come in a certain way, or the order set in the computer is pre-selected to A, B, or C. So it happens a lot that the medications are given based on ease, and we wonder why we're not getting the adequate pain response. I'm going to discuss these in order. So starting with ketamine, the American College of Surgeons Committee on Trauma and the best practices say analgesic dose ketamine is the ideal primary analgesic because of its limited hemodynamic effects. The ketamine dose is actually 0.1 milligrams per kilogram to 0.3 milligrams per kilogram. Going right in the middle of that at 0.2 milligrams per kilogram, that stays into that analgesic dose ketamine. So one thing that I've always learned and I've always taught about ketamine is either go low or go high. Don't go in the middle. 0.1 to 0.3 milligrams per kilogram for analgesic, and then it's 1 to 2 milligrams per kilogram for the sedation. When you get in the middle of that, that's when you start getting into the K-hole, you start getting into these hallucinations and some of the more challenging components to manage in ketamine side effects. So for the pain analgesic dose, maximum dose is 30 milligrams. BSO protocol is reading 25 milligrams. The other issues with ketamine is that some of the other times complications tend to arise is when it's given at the wrong dose or it's given too quickly. So again, follow the protocol based on ketamine administration and always anticipate potential effects and how you're going to manage them. So going into fentanyl next. So again, we had already discussed this is the Broward Sheriff's Office frontline medication with the exception of hypotension. The appropriate dose for fentanyl is 1 microgram per kilogram IV. In the protocol, it reads 100 micrograms as your dose. I'm giving you an example of a 60 kilogram patient. 60 kilograms, 1 microgram, you're giving 60 micrograms. You take that the other way, you have a 150 kilogram patient, and you give them 100 of fentanyl. Pain's probably not going to be controlled. So if you have a very frail elderly patient that's in a trauma with an obvious long bone fracture and you want to give them pain management and you're going with your frontline medication, you may need to consider the dose. You may need to give them a little bit less dose, and you can justify that and we can discuss it. Or, hey, I want some feedback on this case that I had. So that is the appropriate dose based on the pharmacology literature. However, follow your protocols. Going down to morphine. So this is, again, the secondary of the primary if the fentanyl is not available. But something else to consider, you may be doing interfacility or long-distance transports where you have a 50-minute transport time, or the patient already received fentanyl, whatever it may be, and you may need to go with morphine. This is also a common mistake in the emergency department in terms of how this is managed, is the dosing. So a lot of times in the hospital setting, not just the emergency department, it's 2, 4, 6, 8 milligrams of morphine. And that's how you get, very rarely is it given weight-based, but the appropriate weight-based dosing is 0.1 milligrams per kilogram. So again, a 60-kilogram patient should actually be getting 6 milligrams of morphine. So if not, anticipate that their pain's probably not going to be that well controlled. Then going on to the non-narcotic medication management option is acetaminophen. So this can be for very mild pain. So typically someone will give you a pain scale of a 1 to 3, or someone says, hey, I don't want any narcotics, I don't want anything whatsoever IV right now. Then this is something to consider. A lot of multi-system, especially trauma patients, and the safe bet for all emergency department patients, and that's my practice, is to keep them in an NPO status. You don't know if there's something that may be kind of hiding out that's going to require surgical intervention or procedures, and you're now giving them something by mouth. So something just to consider, but this is another option. The appropriate dose is 15 milligrams per kilogram with a max dose of 1,000 milligrams. Most of the time, bigger adults, give them 1,000 milligrams. Smaller adults, you can give them 500. Depending on whether you have the 325 or 500 tablets, we'll kind of go from there. But I want to at least bring up the different options that are out there and different types of literature for pain control, and then compare it to the BSO protocols. So you have to keep in mind that there is no one-size-fits-all for our patients. So here is the U.S. Army Standard Medical Operating Guidelines Pain Management Algorithm. So I wanted to include this because you're going to see some similarities in this, and you're going to see a lot of the same common agents as we had in previous slides. So the big things are in the box on the side. There's going to be a couple of things that say ketamine is neuroprotective and is recommended as first-line analgesic agent per TCCC, which is the Trauma Combat Casualty Care, which is a program administered by the NAEMT. Obviously, here it's saying ketamine is first line. American College of Surgeons Committee on Trauma Best Practices also said ketamine first line. So don't be surprised if we kind of go that way in the future, although right now fentanyl is still our frontline agent. It also gives you some pearls in terms of ketamine-associated psychiatric distress or ketamine-induced agitation, how you're going to manage that. We're going to go over here to the middle part of this algorithm. So it kind of talks about how in the middle box, it's going to say moderate to severe pain, which is a greater than 3 out of 10. If the patient does not have that, they have a pain scale of less than 4, so a pain scale of 1 to 3, then you can consider 1 gram of acetaminophen. We kind of mentioned that before. And if you need something where they need more relief, they have an indication for IV or IM medications, put the monitor on, make sure you're monitoring the SpO2, and then go ahead and give them the pain medication best indicated for their condition. Again, there's no one size fits all. And the medication options are in that box, kind of the green box on the right or middle, however you want to look at it. But it starts off with fentanyl. It gives a range here of 50 to 100 micrograms IV or IO, 100 micrograms intranasal. So there's the range on the IV IO because there's not a one-size-fits-all. It's more of a weight-based thing. So something to keep in mind, that's the reason they give a range. On the ketamine side, it highlighted in red, the TCCC recommended dose is 20 to 30 milligrams, slow IV push over 20 minutes, every 20 minutes as needed. But if you look at it, it's 0.1 to 0.2 milligrams per kilogram IV or IO. Same thing that I mentioned before. You're safe with a 0.2 milligram per kilogram. Once you start going higher than that, then you start getting into the bad parts of ketamine. It's a little bit higher dose if you're doing it intramuscular or intranasal due to the volume and distribution of the medication and the onset of action. So something to consider if you're giving it that way. Going down to morphine, there's actually a typo on this one, which I had kind of already addressed in a previous slide in regards to weight-based dosing, but I've also kind of discussed with some of the people at the Department of Defense Joint Trauma System Conference, which I am getting ready to speak at again. But the morphine dose here, it says 0.01 milligram per kilogram for weight-based dosing. It's actually 0.1 milligram per kilogram. Dosing here, it says 5 milligrams IV IO every 1 to 6 hours as needed. But in the red, it's longer lasting. There's more side effects. You can have histamine release, so you can have almost an allergic reaction type thing, but it's actually not an allergy. It's more of a histamine release based on the medication. And then there's obviously risks of hypotension, respiratory depression. We don't carry hydromorphone, so I'll kind of skip on that. And then Toradol, same thing. Going the next thing on the algorithm, the next arrow down is going to be Zofran, which we had talked about. It's also in the BSO protocol. So this concludes my rapid delivery of pain management in trauma patients. Obviously, it's a very broad topic. There's a lot of, what about this? Can I do this? Right now, we're asking you to stick to the protocols. We're open to discussion and learning more about what's best needed to take care of our patients. But the big key points that we discussed earlier, know that even on short distance transports, you want to take care of these patients. Monitor and reassess these patients. Even the short time that you're with these patients could have meaningful, long-lasting effects on their ability to return to work, their mental health. So we want to make sure we treat these patients appropriately. If you're not getting the response you're looking for after you deliver the appropriate pain medication, is it a dosing problem? Something to consider. Do we need to redose? And if it's one of those where you're not getting it, you think you dosed it appropriately, or hey, maybe I think I could have done more of a dose, or less of a dose, but this is what the protocol said, let us know. We're happy to review it. I'm always interested to look at the case and figure out, hey, what could we have done better? How could we have managed this patient's pain differently? Do we need to adjust the dose? Always wanting to learn so we can provide the best care for our patients. Always reassess, keep them monitored, and don't forget about the non-pharmacologic options. Talk to these patients, set goals, reevaluate, hold their hand, talk them down. Whatever it is, the more we can do, the better it is. So I appreciate everyone's time and attention. Thank you very much. And again, if at any point anyone has any issues or concerns, please reach out, let us know, and happy to work together through all of this. Thanks again.